Pediatrics, Chapter 34, Pediatrics, Part 2, continuing. Anatomy and physiology. Pediatric patient's body is growing and changing rapidly during childhood. You have to consider that a pediatric patient begins life as a neonate, possibly weighing as little as 1 to 5 pounds. Of course, that would be a very small premature neonate. We determined in a previous lecture that even a full-term infant or neonate weighing less than 5 pounds is considered a preemie. So begin life very small and quickly grow. Consider that possibly by the time this preschooler becomes school age and is 6 years old, they may have grown 2.5 feet further in height and could have added 45 to 50 pounds in body weight. You can see just rapid growth. That brings rapid change. Again, children aren't small adults. They have unique physical characteristics. Their anatomy and physiology is changing throughout the growth process. Let's take a look at a few things. The respiratory system. Number one, the pediatric airway is smaller in diameter, shorter in length. Lungs are smaller, and the heart sits higher in the chest than an adult. You can see in this diagram compares and contrasts the respiratory anatomy of a child and an adult. Tongue is larger in relationship to the remainder of the oral pharynx. Child's upper airway, their posterior oral pharynx becomes blocked more readily with the tongue. Their glottic opening is higher in the neck and it's positioned more anteriorly in the neck. That becomes important to us as we progress to the advanced level and we start to intubate children. We'll see that they can be more challenging to intubate because it's more difficult to get that laryngoscope blade up and lift the epiglottis. That is not a problem for a basic EMT. This is a good time to mention it because I want you to start getting that in your heads as you advance as an EMS clinician. As child develops, the neck starts to become longer. That's great because they start life as a no neck. They have very little neck. They have very underdeveloped neck muscles. And if you think about infants that you've been around and possibly you've held, they have trouble controlling their heads. And if you don't support their little heads for them, they flop all over the place. Just kills me when I see someone handling an infant without managing their head for them. So be cognizant of that as you're taking, as clinicians, as you're taking an infant from a parent and you're managing that infant. Be sure to support that head. You don't want to upset the parents. If you fail to control the head, you could lose the confidence of a parent and never get it back, and they're not going to trust you throughout your patient encounter with that child. So make sure you control that head. As the neck becomes longer, the vocal cords and the epiglottis move into the correct adult anatomic position. This happens over time. If you were to try to visualize the vocal cords of a preschooler, you're still going to find them to be very anterior, meaning that their glottic opening is toward if they're supine, it's toward the anterior portion of their neck. Thinking back to your American Heart CPR class, remember that pediatric patients have a rounder occiput. Their tongue is proportionally larger, as we already mentioned. They have a floppy, long, U-shaped epiglottis, which later in your career you'll find can be challenging for some folks to manage as they start to intubate a child. And then cartilaginous rings of the trachea aren't as tough, they're not as stiff, so if you hyperextend that pediatric patient's neck, you're going to flatten out that cartilage and you're going to obstruct their lower airway where the trachea is, and you're not going to be able to ventilate them. How do you fix that? You just move that head back more to a neutral position, patting under their shoulders, and you're going to be able to ventilate that child just fine. Upper airway it's funnel shaped, it's cylindrical, it's a perfect size for a stinking grape or a toy, anything of that nature, to be funneled down to provide an airway obstruction deep in the upper airway. Remember, the larynx divides the upper and lower airway, and you can have quite a problem that may require ALS skills to retrieve that, recognize that early, and get ALS on the way. And then you're going to engage your BLS training for removing a lodged object. You're going to do back blows, you're going to do chest thrusts, and then an older child, you can, as they get large enough, you can do abdominal thrusts. But we're talking toddlers primarily, and smaller, that get these airway obstructions. Kids explore you put an infant on, or put an infant on the floor when they start to crawl, and they explore the world with their mouths, just like a puppy. They want to put everything in their mouths. I don't understand that. I guess maybe they want to eat all the time, but they end up occasionally with a very severe upper airway obstruction that takes a lot of work to clear. Diameter of an infant's trachea is about the size of a drinking straw. If you were to go to your favorite local soft drink dispenser place and go through the drive-through and get one of these big 44-ounce drinks like I'm nursing over here to my left, this straw right here, which you can probably barely see, but that little straw is about the size of an infant's trachea. Why is that a problem for us? Secretions, blood, swelling can easily obstruct that upper airway, and that becomes quite a problem for our patients. Infants that are obligate nose breathers, there's a good logical reason for this in my mind. While an infant is nursing, their mouth is occupied. They still need to breathe. So they were created to breathe through their noses while they're nursing. That's my 2 cents worth on that. So for whatever that's worth. Normal respiratory rate, 20 to 60 breaths per minute for a newborn. Quite a range. You'll also notice with newborns, because of an underdeveloped neurologic system, their respiratory pattern can be very irregular. That can be quite alarming as a parent. Your beautiful little baby that you're hovering over, and maybe you're like me and you have an extensive background dealing with critical kids and dying kids, and as a clinician, and now you have this beautiful baby, and you stand there and you watch that baby breathe, and that baby has short apneic periods, and you almost freak out because you're a brand new parent. You waited all these years to have this little baby, and now, oh gosh, he stopped breathing. Oh wait, oh no, he's breathing again. Very irregular. As in a matter of a couple of weeks, neurologically, they develop and progress to the point that their respiratory pattern becomes more regular and the depth of their respirations become relatively uniform, whereas they have shallow and deep respirations, irregular respirations early on. Don't be alarmed by that unless, of course, they have extremely long apneic periods, and then we need to check into that. We don't want to let babies go without breathing for a long time. These babies they're from the time they get here, they are consuming nutrition and growing and getting rid of waste products. Consuming nutrition, growing, getting rid of waste products, and a lot of this happens all at the same time. That means that they have a high metabolic rate. That high metabolic rate increases their oxygen demand, sometimes up to even twice that of an adult, based on the body weight of that child. So that can be quite an oxygen demand. The thinking about anatomic differences, let's move on down to the chest. Those little infant ribs are very soft, they're very pliable. When intercostal muscles try to contract, they don't really generate chest rise. What does that mean? That means that infants are diaphragm breathers. They're diaphragmatic breathers, and the muscles of their diaphragm dictate their tidal volume. They're belly breathers because the chest doesn't give us any good chest rise. It doesn't give us anything to create negative air pressure. So the diaphragm contracts, and you see their abdomen move. It relaxes, their abdomen moves again. They're belly breathers. If you see an infant with chest moving and abdomen moving, and they're alternating, you see that chest go up and the abdomen goes down, and you see the abdomen go up, the chest goes down. We call that seesaw breathing. That is an ominous sign. That is a child who is in profound respiratory distress. You need to immediately start ventilating that child, bag assisting that child with BVM with 100% O2. Just that normal, once every 3 to 5 seconds, just enough tidal volume to generate chest rise. Again, we want FiO2 of as close to 100 as we can get. How do we get that FiO2 up to that level? We use a bag valve mask, and that bag has an oxygen reservoir, and we provide sufficient oxygen flow from our regulator to keep that bag inflated, and you're going to push almost 100% FiO2 with that. Very important. So, other things with this diaphragmatic breathing, this belly breathing, we call it. They're really not breathing with their belly, you know that. But anyway, they're creating that negative air pressure in the chest, which allows air to move in, as we've talked about all semester, allows air to move into the lungs. And so that's what we're talking about with belly breathing. If anybody from another program were to watch this on YouTube, I don't want them to get the wrong idea there. So if we have diaphragmatic breathing and we have gastric distension, that can create a problem, right? If we have an overinflated stomach, let's say, how could that happen? Oh man, too much tidal volume. If you're having to bag an infant, you're going to be big time in your fight or flight response, or your partner is going to be big time into fight or flight response. Going to have to take a deep breath yourself, slow down, focus, and provide just enough tidal volume to get chest rise, because if we provide too much tidal volume, we get overzealous with that bag, we will quickly fill the stomach with air. That is going to compromise the contraction of the diaphragm, and we have made a bad problem worse. And at the EMT level, there is nothing within your scope of practice that you can do to decompress that that child's stomach. I guess you could try pressing on the abdomen and hope that you can move some of that air back out. BLS level, that's what I would try to do. I don't know that it will work. You may need a paramedic with a small orogastric tube to place that tube in the stomach and decompress that air. So don't create that problem, all right? You know how to do that. We've done that all semester, but this is going to be a stressful event for you as a clinician. You're going to have upset parents. You're going to have other responders on the scene who are freaking out because this is a baby not breathing, or this is a baby who's critical and not breathing well enough. You need to be the team lead, and you need to get everybody under control, working as a team, and you direct that tidal volume. Breath sounds are much easier to hear through a thin chest wall. All you have to do is go out and learn what you're listening for, right? That takes experience. I have this magic invention. I don't know if you've heard of it. It's called YouTube. You can go out there and find all these adventitious breath sounds and listen to those, learn what they sound like on YouTube, and I'll bet you they'll sound close when you auscultate that chest of an infant, a child, an adult, anybody. Go listen to those, learn what they sound like. Remember pulse ranges. Infants' heart rates can be irregular. Can even push up to, in a neonate, push up to 160 beats per minute. Wow, man, that's going to be difficult to count. You are going to have to practice taking an apical pulse of an infant with your stethoscope, using the bell side or the really small diaphragm, and you're going to have to listen closely. I recommend finding the loudest sound there, and you count every time you hear that loud sound, and we're going to go a full minute with an infant so that we know what that heart rate is. Again, I said in a young infant, that heart rate can be somewhat irregular at times, and respirations, even in an adult, respirations can slightly change the heart rate so that you don't, or so it isn't as regular, change the heart rhythm so that it's not quite as regular. That doesn't happen all the time, but you may find that may or may not be a big deal. We'll learn how to assess that when you come back for paramedic school. Don't want to give too much away now. You hadn't paid for paramedic school yet, so I don't want to give that to you yet, right? Children do a really good job of compensating for decreased cardiac output without regard to what the cause is, whether the cause is hypovolemic shock and they peripherally vasoconstrict. I mean, just out of this world vasoconstriction. They have almost brand new car they're driving, right? Everything works really well. So they vasoconstrict really well so that when they compensate, you may even find that all of their extremities are cool, pale, weak pulses, poor cap refill. Central circulation's looking pretty good, but peripherally there's a big problem, and you need to investigate and find out why. This little table from your book gives you the normal heart rate for different ages of children. Take a look at that. I've told you all along, make yourself a little cheat book that you carry with you when you start working, and in there you copy all these tables and you paste them to pages of paper in your little book, and you have a pediatrics section and you're dispatched to a pediatrics call and you start thumbing through, so you're refreshing. Oh yeah, heart rate is you under the gun, especially until you have some experience. It's easy to forget these things. So make yourself a cheat book. Okay. I don't want to repeat myself. Some of these bullet points are here over and over and over. Subarachnoid space in the head. Remember, that's where cerebrospinal fluid circulates, and CSF, cerebrospinal fluid, provides a liquid cushion to protect the brain. But that subarachnoid space is smaller in a child. That leaves less cushioning for protection. So that head trauma can be devastating. And brain tissue and cerebral vasculature are fragile, prone to bleeding from shearing forces. Where can these shearing forces come from? Let's think mechanism of injury. Shearing forces, where did we find those in general? We found shearing forces from vehicle rollovers and from rapid rotational forces, from, say, vehicle being struck in the back quarter panel and causing it to spin, and you have those rapid rotational forces. The biggie with infants is shaken baby syndrome. Somebody that I'd like to have about 10 minutes in the woodshed with folks who do this. They're frustrated, they're whatever. I don't know what causes people to do this. Pick up an infant and just shake the thunder out of them like they're a rag doll. I wouldn't even shake a rag doll because it would remind me of somebody shaking a baby. They shake the baby, and we get several different injuries to the brain and to structures within the brain. So the brain tissue itself, we call it axonal loading and unloading. What's happening? The axons of the nerves, all these millions of nerves in the brain, are being stretched. Some are breaking, some are being stretched to the point they start to tear but don't break, and then they snap back together, and it's just demolishing brain tissue. And as if that wasn't bad enough, then this fragile cerebral vasculature within the heads of these babies start to tear, and some are micro tears that create small bleeds, and then the catastrophic ones that leave a baby just dead within minutes to maybe an hour would be a tear of one of the large cerebral arteries, and then that's just like a hemorrhagic stroke, and they just bleed out into their heads. So that is a major deal, and that's what's happening in shaken baby syndrome. That is a trauma that can create anything from a dead baby to a child with horrible developmental delays, maybe even just a bed-bound person for that person's entire shortened natural life. So big deal. Pediatric brains have higher cerebral blood flow. They have a higher oxygen demand and a higher glucose demand. Pediatric patients are susceptible to secondary brain damage from hypotension, also from hypoxic events. Sudden infant death syndrome is one of those. Several theories on that we probably won't even go into today, I don't think. And then high glucose demand, and if that child isn't receiving the nutrition needed to maintain that constant supply of glucose. You can have secondary damage to brain tissue from being hypoglycemic. Spinal cord injuries, less common. You don't see as many of those with small children. They seem to be pretty well protected there. And then if you do have a suspected neck injury, manual inline stabilization, possibly place that baby on a backboard, secure that baby in a car seat, and pack around them to stabilize them. You're not going to get a cervical collar on there. It's just, there's no neck there to put a cervical collar on. You will cause other problems by trying to we just don't have cervical collars that small, for one thing. And if you did, I don't know that I would recommend using it. Okay, abdominal muscles are less developed. That if that child experiences blunt force trauma to the abdomen, more susceptible to liver lacerations, spleen lacerations, kidney trauma that results in retroperitoneal bleeding, as it with blunt force trauma to this child's abdomen, with the liver, spleen, and kidneys being more packed in, more anterior, closer to one another. There is a higher risk for multiple organ injury, resulting in multiple organ failure and death. So, okay, moving on to the musculoskeletal system. Open growth plates allow bones to grow. A fracture in an epiphyseal plate can cause that epiphyseal plate to ossify or close, and that bone ceases to grow, and you have discrepancies in bone length. As you know, the infant's head flexible. The fontanelles are not ossified, so more likely to I'm sorry, let me back up. That initially provides a mechanism for the compression of the head and then the baby to be delivered. And then later, that's a good indicator of hydration. That's a good indicator of dehydration. And then if you have something such as meningitis, you have an infectious process of the meninges, and you can see a bulging fontanelle. And then as you move into the ALS level and you're providing IV fluids, a bulging fontanelle is a sign of overhydration. You got carried away and didn't watch your IV fluid, or you were a little too overzealous and you pushed too much fluid. Okay. Integumentary system, thinner skin, less sub-Q fat, more susceptible to heat and cold exposure. Okay, let's hit scene size up. At dispatch, we hear infant or child, and we instantly freak out and panic and forget everything we know, right? No, we need to start thinking through, I'm being dispatched to a pediatric respiratory issue. Does that mean that's what you'll find there? No, that's from what the dispatcher could ascertain from the caller. That's what it seems to be. So that can change when you get there. So start thinking through the chief complaint from the time of dispatch, nature of illness, mechanism of injury. They'll tell you the gender and age of the child. Are you going to a neighborhood where there are $1 million homes, or are you going to a row of houses that you know to be where they're cooking meth in one, there's a crack house in the next one, There's I started to say something else, a house of prostitution in the next house, and then the next one, some little old lady still has a knife shard there. Scene safety, people can freak out when their child is sick or injured, and if they don't think you're doing what you're supposed to do, then they can get really excited. Only a few times have I seen somebody become physically confrontational or attempt to assault and batter a crew on scene, or even myself on a pediatric call. Don't let your guard down, though. Okay. Trauma scene, scene size up. Was the child secured properly in a child safety seat? Was the child loose in the passenger compartment and thrown around and bounced off of everything inside that vehicle and then came to rest in the floorboard of the vehicle? You need to inquire into those things. Okay, pediatric assessment triangle. Assessment of all of our patients should begin through the door assessment or across the room assessment, whatever you want to call it. This is less than a 30-second thing. We walk through the door, we look, what's the appearance of the child, what's the work of breathing of the child, what's the circulation to the skin. You're forming a general impression prior to ever touching this kiddo. So 3 steps: appearance, work of breathing, circulation. Appearance, what's the level of consciousness, interactiveness with you? Do they track you with their eyes as you come through the door, or they just limp lying in the crib? You can still use the AVPU scale for their level of consciousness, their mental status. Is their level of consciousness age appropriate? They're not going to be able to tell you who the president is and what day of the week it is and all of those things. For their age, do they appear to be interacting appropriately with you? Do they have good muscle tone? Are they moving their extremities around? Or do they have flaccid extremities and kind of a glazed look in their eyes? Those are bad signs. Are they able to maintain eye contact? And then you can employ the Tickles mnemonic. Tone, that's muscle tone. Interactiveness, how they interact with you. Consolability, they're screaming and crying. Are they able to be consoled? Not necessarily by you, but by a caregiver or someone there on the scene, a parent. Look or gaze, do they make eye contact, or do they just, they don't track you at all, they don't make any kind of eye contact with you? And then speech or cry. If they're old enough, can they speak to you, or can they make verbal sounds? If they're an infant, then are they crying or not crying? Do they appear to be so sick that they don't cry? Work of breathing. Are they fighting to breathe? Do you have accessory muscle use? Retractions, suprasternal notch, right at the superior, just superior to the sternum and between the clavicles, the suprasternal notch there. That's a good place to look for retractions. Accessory muscle use. Are they seesaw breathing? Do they have retractions? Are their intercostal muscles sinking between their little ribs? Head bobbing. That means they're getting tired. If they're head bobbing, let's get a bag valve mask, connect it to O2, and let's start bagging them. And at appropriate tidal volume and rate. And that head bobbing, they're worn out. They're fighting to breathe, and from head bobbing, you're going to have a child in respiratory arrest in a short time period. Nasal flaring. Remember, they're obligate nose breathers. Their little nares are flaring as they attempt to breathe, and then they may be so tachypnic that they're ineffective in generating sufficient tidal volume. And then if they're old enough, they may be sitting in that tripod position. Circulation to the skin. When cardiac output drops, blood shunts from areas of lesser need to greater need. What is that? Peripheral vasoconstriction shunts blood to central circulation to increase cardiac output by increasing venous return to the right side of the heart, and that increases preload, and that increase in preload is going to increase pulmonary perfusion, which is going to increase circulation to the left heart, and then that is going to kick that Frank-Starling mechanism by filling that left ventricle, causing it to contract harder. Now you've used preload to generate stroke volume, and then that's going to help increase afterload also. So all of that's going to work together to increase cardiac output. We need to also, especially in darker pigmented kids, darker pigmented skinned kids, you can look at their mucous membranes to see if they're pale, to see if they're cyanotic. You can see if they're dry because that child is dehydrated. You can get some really good clues from there. From your pediatric assessment triangle findings, you'll decide if you have a stable child or you have a critical child. They require urgent care. We can't mess around. We have to get on the stick. We have to know what to do, and we have to do it. Have to manage that airway first and that breathing second, and that is in rapid succession. Pediatric patients go into cardiac arrest because of respiratory failure. They don't go into cardiac arrest because of dysrhythmias like adults do. So if we can treat the respiratory issue, we can manage the cardiac issue, because our cardiac issue comes second to the respiratory issue. Life-threatening hemorrhage, we can even use tourniquets if we have massive trauma to an extremity. This is rare, but if you find that, we can we're working through circulation, airway, breathing, and circulation. We can use tourniquets to manage bleeding. If this patient's stable, you can continue through the rest of your assessment process. This is a hands-on activity. This is a toe to head hands-on activity. Kids don't like to have their heads monkeyed with. They get mad. They scream. You can't console them. You can't hear breath sounds. You can't auscultate an apical pulse. All you can do is listen to a kid scream and cry, and you can't do a good secondary assessment. So we start at the feet and work up. We're going to assess life threats: airway, breathing, circulation, disability, exposure. What's the environment? That's the one that could be different. Are they in a super hot room? They're in a super cold room. They don't respond well to extreme temperatures. So let's go back through A, B, C, D, E. Airway. I got ahead of myself as always. Airway, is it open, patent? Is their respiratory effort adequate? If not, fix it right now. What's the purpose of primary survey? going to find life threats, we're going to fix them, and we're not going to move on until we've done so. So we need to clear their airways. In an infant, how do we suction them? Suction them with the bulb syringe, right? If they have a snotty nose with crusty boogers in it and they're fighting, one side's plugged off and the other one they're fighting and snot slinging in and out as they try to breathe, if we can get that bulb syringe and suck their little noses out, and we may clear up a little bit of that distress that they're having. They're not going to switch and breathe from their mouths. They're not neurologically to the point, or they're not developmentally to the point yet that they're going to breathe out of their mouths. We open their airways with the head tilt, chin lift, or jaw thrust maneuver. The jaw thrust is going to be more difficult with them. We need to keep their posterior oral pharynx clear of vomit, blood, any foreign bodies. Again, find it, fix it, don't move on till it is fixed. We need to pad under the shoulders, get them in that neutral stiffing position as we already established. Breathing, look, listen, and feel. Do we have good respiratory effort? Remember, we're not going to see chest rise and fall. We're going to see abdominal rise and fall. You can put your hands lightly on either side of the chest and you can feel it move out a little bit, but belly breathing is normal. It's considered adequate. Bradypnea is an ominous sign. How does that happen? Let's talk through that really quick. I said that kids, they become dyspneic. They go from respiratory distress to respiratory failure, and it's like falling off a cliff when they go into respiratory failure. What happens? They're tachypneic. They're fighting to breathe. They fight, breathe. They're using accessory muscles. They're fighting. They're seesaw breathing, and they just get worn out. Maybe that head was bobbing before we got there, but we get there and they're bradypneic. They are in respiratory failure at that point, and they are just a notch away from respiratory arrest. We need to be aggressive in managing their respirations. We do that with our friend the bag valve mask, right? Circulation, how is their color? Take a pulse, whether it's a brachial pulse or an apical pulse. Is there bleeding? Let's manage it. Is that patient in shock? We need to deal with it. That may be that we need to call ALS so they can give fluids. We can't do that, but we don't need to mess around here. We have to make quick decisions, very purposeful decisions, call extra help early, including ALS. Can also palpate a femoral pulse. It's easy to palpate. This would be the pediatric patients are going to be the easiest to learn to find a femoral pulse. I don't recommend doing that to strangers, kids. You need to practice. So if you have family members with children who will let you do that under the watchful eye so that they know what you're doing, you're not accused of something funky here. Just say, hey, I'm in this EMT class and I really need to learn something about kids and I need to practice assessments and little Tommy knows me, so would you mind if I got practice taking his pulse, maybe his femoral pulse right here, and show him where, and then I'd like to take a stethoscope and listen to his chest and learn to count an apical pulse. Maybe it's your friend's kid, but I would recommend getting some practice. Strong central pulses, because children under 3, it's difficult to take their blood pressure. Strong central pulses, which would be that femoral pulse, that's an indication that we have a, a fairly normotensive child. At least they're probably not hypotensive. Uh, Weaker absent peripheral pulses, that's decreased perfusion. Uh, that could be shock, so that blood has been shunted to central circulation. Tachycardia is an early sign of hypoxia. Kids don't go out and run a mile, so as they become hypoxic, they try to compensate by increasing their heart rate so they can increase perfusion. Okay. Trend their vital signs as always. Is their heart rate increasing or is it decreasing? Was it initially too fast, but they're tachycardic, but we got some oxygen on them, and now we're resolving that hypoxia, and their heart rate's moving back to a normal range. What is their skin temperature? If you have a bradycardic little one, that's an ominous sign also. That is a sign of impending cardiac arrest. So we're going to treat that with respiratory management. We're going to assess circulation to skin or circulation to the extremities with capillary refill. We're not going to squeeze their little fingers and their little toes, too small to really see. So you're going to push on the side of the heel until it blanches, that kind of white color, release, and it still should be less than 2 seconds for cap refill. And then we can use their little chubby hands, the back of their hand, the dorsum of their hand, to do the same thing. As we said, we can use the APU scale. There is a separate pediatric Glasgow coma scale. True confession time, I don't always remember it, and I've been at this a while. So again, your little cheat book, have that handy, because it is important. Pupillary response, are their pupils equal, round, reactive to light? Are they sluggish? Remember, I've told you since the patient assessment chapter that sluggish pupillary response, one of the things that could be a big indicator of is hypoxic, cerebral hypoxia. So if we have sluggish pupils, if we can resolve airway issues, either upper or lower, and we can use a bag valve mask to deliver appropriate tidal volume and rate, and get that chest rise, regardless of how fast the kiddo's breathing, we can still bag at 12 to 20 times per minute, and just enough to get chest rise again. Okay. Pain. We can't ask on a scale of 0 to 10. That doesn't work. So for a child who's a little bit older, maybe an older preschooler or a school-age child who doesn't quite have the cognitive ability to do the 0 to 10 thing, there's a little Wong-Baker faces scale, and you can have them point to which one is how they feel with their pain. That takes some pretty good communication to do that. So, but it is a mechanism that you can use. Transport decision, make that transport decision, err on the side of caution, I say. Rapid transport if. Here we go, here's the laundry list. Significant mechanism of injury, history compatible with serious illness. Even if we're not quite seeing it yet, if they have a history of serious medical issues, underlying medical issues, then we can err on the side of caution with rapid transport. We need them in the hands of somebody who's familiar with their problem and can do something about it. Then significant pain, abnormal level of consciousness. Consider the type of clinical problem they present with. Of course, any life threats that we identify in our primary or secondary survey that's gonna trigger a rapid transport. Will they benefit from ALS in the field? Are they critical to the point that we need to have ALS meet us on the way and take over care? Does ALS have a response of half a block, and they can be on scene with us, and they can provide fluid resuscitation, advanced airway, the things that are in their scope of practice and based on their training that you're not quite ready for yet, and you definitely don't have the certification level for it anyway. And then your local protocols, your comfort level, transport time to the hospital. We can use, in a child less than 40 pounds, we transport them in their car seat with it properly secured to our stretcher. That's a great way to immobilize a child. That's a great way to protect a child. We can strap the parent in the back with us unless we suspect a severe child abuse situation. We could secure that car seat in the captain's chair in the back of our ambulance. I still recommend going with securing that to your cot with the cot straps and properly securing that infant or child in that seat. Spinal immobilization in an older child, we'll use a long spine board or suitable spinal immobilization device. In a younger child, that green KED that we used in lab for a short spinal board and for short spine board immobilization, that works great as a backboard for an infant or a toddler. CPR, you know what to do. You know how to do that. History taking depends on the age of the child. Are we going to get history from the caregiver, or maybe with an adolescent we can get history from them? Stick to the chief complaint and the problem you're seeing in front of you. Don't go into a full lifetime medical history. We need past pertinent medical history in connection to that patient's chief complaint. Nature of an illness, mechanism of injury, we need to ask questions about that. The link of an illness or of a child or injury, events leading up to that injury or illness. Has that child had a fever? Has the parent administered any medications for that fever? Any antipyretics that would mask a fever or lower a fever? Where could that be important? If you have a child with bulging fontanelle and nuchal rigidity that we'll talk about in just a moment, they might appear to have meningitis, but wait, they don't have a fever, and you said they could run a high fever, and well, have they been given medications for that fever? It may be much more difficult to control a fever with meningitis. That can cause a really high fever. Changes in activity level. Is this current activity level normal? Any recent eating and drinking habits? How has that changed? Are they nursing well? Are they taking, if they take bottles, how many bottles are they taking in a 6-hour period or an 8-hour period? How does that compare to normal? Have they stopped nursing altogether? Have they stopped drinking altogether? What's their urine output? How do we determine that? How many diapers are they soaking? Changes in bowel habits. Does it look different than normal? On and on. Any vomiting, diarrhea? There's a difference in vomiting and spitting up. Spitting up, that's more of a just blub blub blub, and it's a lot of times it's just a immature cardiac sphincter that allows that child to spit up when they have their stomach full. Vomiting is vomiting, like, I mean, serious emesis. So distinguish between spitting up and just downright vomiting. Spitting up happens after meals. Vomiting can happen for a considerable period of time after nursing, and then diarrhea, abdominal pain. Any blood in the diarrhea, child with abdominal pain, maybe just obviously in pain and in distress, and then passing some blood in their stool. That could be sign of intussusception of the colon, where it kind of folds over itself and it can spasm down and stop circulation, cause an ileus, cause a weak place, cause a ruptured colon. Depends on how long that persists. That can be a life-threatening situation. If that colon perforates and you have fecal matter throughout the abdomen of that child, they can go into septic shock and die in a hurry. So that blood in the stool is not normal. It's not something they ate that caused it. If there is some blood in their diaper when they have bloody diarrhea or bloody stool, that is very noteworthy. That necessitates transport and evaluation. Sample history is sample history. There are questions we need to ask based on the child's developmental age, of course. But last oral intake isn't going to be a 6-pack and a steak, but probably. And then OPQRST, that can be a little more difficult depending on the developmental age of the child and who we're getting the history from. Secondary assessment with trauma, we're still going to use DCAT BTLS. Your friend that you learned way back there in Chapter 9. That's a long time ago, folks. Okay, I'm only going to hit the things that we haven't already covered as I go through here. As we examine the head, once we get up to that, we're going to look for any bruising, swelling, any hematomas. We're going to assess the fontanelles in infants. Are they sunken in? Do they appear normal? Are they bulging? How do you know if they're sunken in, normal, or bulging? We need to look at fontanelles of infants and see what normal looks like with our friends and family members' kids. And when we learn what normal looks like, then we can start to note what abnormal is in our assessments, right? Start with normal and learn abnormal. Okay. Nasal congestion, as I said, that can cause respiratory distress. We can resolve that with a bulb syringe or a little catheter suction. Drainage from the ears, that could be from a skull fracture, could be possibly from an ear infection, but even with a perforated eardrum, I don't know that you're going to see anything coming out of a child's ears. So that is an ominous sign if you have fluid draining from the ears. Again, if it's cerebrospinal fluid, the halo test is going to get you there to determine what that is. Okay, in an older child, are there loose teeth? Do they have bleeding in their mouths? Look at the trachea. Does it look like there's any swelling or bruising? Does the trachea, as best you can see it, in a little short neck, does it appear to be midline? All the normal things that we do, right? If you're assessing a child with a high fever and that child cannot move, will not move their head, cannot move their neck if you try to flex their head forward, and you can't flex their head forward, or you can't extend the head back easily. Then that those two things, nuchal rigidity plus a high fever, those can be an indication of meningitis, and that's something that requires quick transport and treatment. Not something we let them stay home and see how well they do with it. They die. That's what happens long term without treatment, or they have profound brain injury. These things just don't resolve themselves, especially with bacterial. I say they don't resolve themselves. Viral meningitis, supportive care is how that's managed, and steroids, that kind of thing. But they're not as aggressive in treatment because that's not quite as aggressive, and you do see that resolve with some supportive care. Without anything, they may not do well. Okay, we're going to inspect the back. Just like we always do, we assess the back using DCAT BTLS. When we assess the back, that's a good time to go ahead and auscultate the apices of the lungs. We do that posteriorly, especially in pediatric patients. That's where we're going to hear best, and then we're going to auscultate in the axilla to assess the bases of the lungs. Those lungs are higher up, so we have to auscultate up here in the axillary area to auscultate the bases of the lungs. Look for abdominal distension. Again, any seesaw breathing that may have developed while you're treating this patient. We know what to do for that now, right? Magic thing called a bag valve mask. Any masses, any tenderness, don't be overzealous in palpating that little abdomen. There's no need for it. Symmetry of the extremities, and do they move all of their extremities? Are their extremities, assess the color, the warmth, and look for any swelling, any tenderness. I have seen an infant with an older infant with a fractured femur. That does not happen naturally. Somebody grabbed that little leg and fractured that femur. Do a good job of a child that just is inconsolable. They won't stop crying. Assess their extremities for the possibility of fractures. You have to put a lot of stress on one of those rubbery little bones. They're not made out of rubber, but one of those flexible little bones to twist it to the point that it fractures. So be aware of that. Okay. Vital signs, heart rate, and respiratory rate. We've talked about those already. Blood pressure is not a useful assessment tool normally in a child under 3 years of age. We're going to look at circulation to skin and central pulses. After 3 years of age, we need a blood pressure cuff that covers 2/3 of that pediatric patient's upper arm. If the cuff's too small, it will give a falsely high reading. If the cuff is too large, it will give a falsely low reading. Okay. Heart rate, 1 to 10 years old, 70 plus, 2 times the child's age in years, is going to give you the systolic blood pressure approximately. So that would give you normal for that child. Your book says count at least 30 seconds, double that number. Just go for a minute. it's a much better assessment. It takes 30 more seconds. It's not that big a deal. We've already dealt with life threats, right? If we're down to assessing this pulse, at least we have somebody managing the airway and respirations, and we made sure there's a pulse, so that we felt a pulse, not counted a pulse yet. So we have those things under control. We're down to the point in secondary assessment that we have time to count for a full minute, or 30 seconds to multiply times 2. Go a full minute, please. Okay, note quality. Is it strong and bounding? Is it weak and thready? Is it regular? Is it irregular? Let's do respirations. We don't have to touch them to do that. Then we're going to do pulse, then blood pressure. We're going to start with the least physical contact because we're not going to have a screaming kid as easily as trying to fight them and put a blood pressure cuff on them. Another reason that we don't worry as much about blood pressures in a child under 3, that we're going to be able to assess. We're going to be able to determine if they're normotensive by the fact that central pulses are present. We're looking for equal round reactive pupils, utilizing your pin light. Pulse oximeter is a very valuable tool unless you have a peripherally vasoconstricted child. Then it's going to be worthless, because you're going to, with an infant, you're going to have the tape on type of a small electrode or sensing device that is on that little one's heel, and if they're vasoconstricted, it's worthless. We don't have one that's small enough to clip over a little finger. They also make one that goes on the ear. Again, with infants, that's going to be on their foot. Okay, Q15 or Q5 minute vital signs and reassessment. Constantly assessing respiratory effort, respiratory rate, and if you have somebody bagging that pediatric patient, be sure and get good feedback very regularly as to bag compliance. Tell your person who is bagging that child to let you know if bag compliance becomes poor, becomes tough. It's poor bag compliance. It's hard to squeeze. Again, we're ventilating like this or like that to get that appropriate tidal volume. But if bag compliance becomes poor, that's a surefire indicator of, well, it could be that maybe they got that little head hyperextended and that trachea is too flat. Maybe that's causing the poor bag compliance. So if they have poor bag compliance, reposition the head. And then if it's still poor, that may be an indicator of a pneumothorax that's relieved with a needle thoracotomy, otherwise known as a pleural decompression. That's not in your scope of practice. You need ALS for that. We don't want to get to that point. Make sure that everybody is careful with that tidal volume, and we're not causing barotrauma, rupturing that lung tissue and blowing air into the pleural cavity. Leading cause of cardiac arrest in children is respiratory failure. So if we can manage the respiratory problem, we can we have a much stronger likelihood of managing the cardiac issue. If we get to the point that kid's already in arrest, it is possible early on that good CPR and good ventilation, we can have a good result, but without proper intervention, we're going to have a catastrophic result, one of the worst ones you can imagine. Early stages of hypoxia, same with adults, combativeness, restlessness, anxiety. That may be tough to pick up on with a fussy kid who has upper respiratory infection, or maybe they develop pneumonia and they're fussy, they don't feel well, and they appear to be restless and anxious, and it could be that they're hypoxic. So, okay. Let's go back. As our pediatric patient progresses from respiratory distress to respiratory failure, breathing efforts decrease. They get tired. They don't fight to breathe anymore. They're just too tired to breathe, so they become bradypneic. Their respirations become shallow. So you see less chest expansion. Where do we assess that? On the sides. You see less chest movement there with inspiration, and so their tidal volume goes down, the respiratory rate goes down. By the time they're bradypneic, they are moving rapidly to respiratory failure, respiratory arrest, and you're going to have a dead kiddo on your hands if you don't do something fast. We know what to do for that. Bag valve mask, right? Altered mental status, altered level of consciousness, level of activity goes down. They breathe, and then they have periods of apnea. They breathe and they have periods of apnea. As the myocardium becomes hypoxic, they become bradycardic. And what do we do for that? Number one, we need to start managing respirations, but in an infant whose heart rate is below 60, we're going to do chest compressions, right? So, and it's possible we can turn this around with proper respiratory management and those chest compressions to hold us over until we can ventilate the child, deal with that respiratory failure, hopefully, and get them back so that they're being properly perfused, and then restore myocardial oxygenation, and that should hopefully reverse that bradycardia. Remember that respiratory failure doesn't always mean airway obstruction, though if there's airway obstruction, we have to resolve that, or there will be respiratory failure. Child in respiratory distress needs supplemental oxygen. Don't hesitate to assist ventilations with that BVM. Hopefully you have that in your heads now, because I've said it over and over for an hour now. More than an hour. Okay. Okay, let's see. Airway obstructors. There's you a good little selection of them. That little funnel, that funnels those things right down there and cause that airway obstruction. And we can use back blows and chest thrusts to remove those. If we can't resolve that, we need to have ALS on the way. And if we can't resolve it, hopefully they can take a laryngoscope and some McGill forceps and get down there and pull that out. My other part one had a description of McGill forceps in there. Suction out blood, vomit, any secretions, and keep those suctioned out so you have a clear airway. Croup, we'll see in a minute, that is a lower respiratory infection, laryngeotracheal bronchitis, and then epiglottitis is upper airway. That is an infection that impacts the epiglottis. Differentiating croup and epiglottitis. Croup, gradual onset, seal bark kind of cough, low-grade fever, hoarseness of the voice as they cry or as they try to speak, inspiratory stridor, and then other signs and symptoms depend on the degree of distress. This is going to be enough to differentiate. Thank you, Illinois Emergency Medical Services Council, for this. Epiglottitis, sudden onset, muffled cough, very less prominent cough. You don't have that seal bark cough. They have a high fever, had that rapid onset, as I said. Inspiratory stridor, that's the same, right? That's one of the few parallels between the two. Difficulty swallowing, which results in severe cases, drooling. That's not universal. You don't always find that massive drooling. That used to be what we taught is the difference. That's what you see. You're going to see that drooling with epiglottitis. They're just going to have slobber pouring down their faces and the front's going to be soaked. And turns out that's not universally true. So we alter our teaching to newly discovered truths. So, over the years, I've been around a long time. I've seen some course corrections along the way, and then maybe tripod positioning. Okay, you know how to manage an airway obstruction. Let's see, with a foreign body, you know what to do with that. Lower airway obstruction. So wheezing, we're going to see that with what causes wheezing. Somebody out there yell it out. Oh, I'm by myself here. I'm talking to myself. I might need mental health evaluation here. Wheezing is we most commonly associate that with asthma, right? Those narrowed, those constricted bronchioles, and that air trapping, so that when you try to exhale, it's harder to move that air through. You get that hyper-resonant chest, and as that air squeaks through that constricted bronchiole that has all those increased secretions and have that, and it's edematous, and it makes that wheezing, almost not really a whistling sound, but that sound that's a characteristic wheeze. Crackles, that's more, we used to call those rhonchi. Crackles are no. Crackles were rails. Crackles, that's associated with fluid. So if we hear crackles in a pediatric patient, we're going to be thinking fluid. We're going to be thinking maybe pneumonia. Epiglottitis, call ALS. Provide blow-by oxygen, very gentle handling. We don't want to cause further swelling through rough handling, cause further swelling of that epiglottis, because then you're going to have an upper way obstruction that you can't resolve. And it may be that the only way to deal with that is a surgical airway, and that's extremely difficult to do in a pediatric patient without a neck. So we have a major problem, we don't visualize the airway. We don't stick anything in the mouth if we suspect epiglottitis, because that can trigger that further swelling. Already talked about how to auscultate the chest. Immediately begin treating an airway obstruction. You know how to do that. I don't even know why I started to go through that. So, asthma, started talking about that. We'll hit it for a minute here. We have inflamed, swollen bronchioles. The smooth muscles of the bronchioles can be constricted. You have bronchoconstriction. You have that inflammation and swelling. You have excessive mucus production in these patients. And that leads to difficulty breathing, because you have air trapping. It's difficult to move that air out so that they can inspire and bring more air in, right? Air goes in and out, blood goes around and around. That is life. If there's something wrong with one of them, we have to fix it, or they get dead on us. So, okay. Up to 10% or more of children in the U.S. are asthma sufferers. Triggers or common causes for asthma attacks: upper respiratory infections, occasionally exercise. We don't see that as frequently as we once thought. Exposure to cold air, or smoke, emotional stress, all of those things. Let's hear wheezing, if it'll work on here. I don't think it's going to work in this platform, but we're going to try. Okay, that's wheezing. Hopefully you heard that. I'm not going to do it. I'm not going to play it again like I do in class, because it's possible that that didn't even make it to that recording. It is possible to have lower airway completely blocked by asthma, severe asthma attack, and that bronchoconstriction to the point that you have a silent chest. No air movement is heard at all when you auscultate. Naturally, you'd find that to be quite ominous sign, especially if it's your child. Cyanosis, respiratory arrest, can rapidly develop. Treatment, position of comfort, administer supplemental O2, and if protocols allow, we can use a bronchodilator, beta 2 agonist, to cause bronchodilation. And if you have it available and you're using a metered dose inhaler, then you're going to use that spacer so that they don't have to try to time the puff in the inhalation. And if your protocols allow, it may be that you're able to give a handheld nebulizer treatment, and you end up with this little bitty nebulizer that has a strap, and it may look like a little animal even. You may be putting a dinosaur around your little patient's mouth and nose and providing that bronchodilator. Slow, gentle breaths if we're ventilating that patient. As always, that's what we're going to do. We're going to do gentle breaths with just enough to get chest rise. I don't care how old our patient is. We do not want to provide too much tidal volume. It's unnecessary. It's damaging. It causes, it leads to bad results. Prolonged asthma attack. That's called status asthmaticus. That is a life-threatening emergency. That is a right now get to the hospital, provide rapid transport, diesel or gasoline therapy, skinny pedal on the right, whatever you want to call it. We got to get up and go get them to the hospital, provide supplemental oxygen. We can call for ALS. They have more tools, more weapons in their arsenal. Remember that if that patient becomes too exhausted, they're going to stop struggling to breathe and they're going to go into respiratory arrest. So we need to manage the airway, provide proper respiratory management, including a bag valve mask where indicated, and get definitive care for that child. Pneumonia, leading cause of death in kiddos. It's most often a secondary infection. So what do we find in our assessment that might make us think of that this child has pneumonia? Maybe they have a fever. They could even be hypothermic, but that would be if they're on the side of sepsis. But they're well into sepsis. Let me say that. Early in sepsis, they're going to have a fever, and then they're going to be hypothermic. Tachypnea, nasal flaring, and grunting sounds. In an infant, grunting sound is a sign of respiratory distress, and I go out on YouTube and find it, but I can't do a good job of making that sound for you without embarrassing myself, and you still won't know because I don't know if you've noticed, but I'm far from being an infant. Okay. Unilaterally diminished breath sounds and crackles over the affected lung segments. Our treatment is supportive. We're going to monitor the airway and breathing status, provide supplemental oxygen. Quite often that's just going to be blow-by oxygen. And then possibly, if protocol allows, administer a bronchodilator to help with that dyspnea. You can only confirm pneumonia with chest X-ray. Croup, laryngeotracheal bronchitis, is a viral infection. You see it most often in kids 6 months to 3 years. It passes like wildfire through a daycare. Get one or a church nursery or something of that nature. You get this croupy sounding respirations, stridor, seal bark cough, and kids just they look really sick. They're lethargic. They don't interact well with you. They have that seal bark cough. See if we can back up to a slide here. Let's see. I want you to hear this. Okay. Sorry. Okay, that's not the right one. This little guy's sick. See us. Okay, just things from assessment from earlier. Retracture. See how that suprasternal notch sucks in. Look at his eyes. He is not engaged with his surroundings. Look at his little abdomen as he breathes. This little kid is in severe distress. Okay, that wasn't the one that I meant to show you first. Okay, let's hit this other one. Let's find this kiddo. Little dude looks sick, doesn't he? Hear that seal bark cough? That's what I'm talking about. That's that croupy seal bark cough. You can't miss it. Okay. Now. Okay, here we go. This is croup. Croupy cough. Okay, those many of those are outside your scope of practice, but I wanted you to see those videos, hear and hear what croup sounds like. So now you know what I mean by that seal bark croupy cough. Catch up with myself here. Starts with upper respiratory infection, a cold, a cough, low-grade temp, and then that progresses. As you saw in that little video, I have that there for a reason, even though it's outside your scope of practice. You hear that seal bark cough, you hear that inspiratory stridor because of that laryngeal edema as the computer voice says. There's several strange pronunciations there that could kind of throw you. Hopefully you figured out what they were talking about. Croup responds well to humidified oxygen. That's another reason we need to have humidified oxygen available in ambulances, but we don't have it. And that's crazy. We have so many things that we need it for. And then bronchodilators pre-hospitally are not indicated. They can actually exacerbate the symptoms, make the child worse, so we don't want to do that. So supportive care, blow by oxygen, and humidified oxygen. That's what we're gonna see. That's what we're gonna utilize. Epiglottitis. This is a immediate life threat. That epiglottis, which is it's already overly large in a child, and then you increase the size of that by 2 or 3 times because of a bacterial infection, and you have a humongous epiglottis that by the time they're symptomatic, because this has a rapid onset, by the time they're symptomatic, they're teetering on the verge of totally occluded upper airway that we can do nothing about. So gentle handling, we need to recognize it. That chart that I showed you earlier, I think, is really good for differential diagnosis between croup and epiglottitis. Smooth handling, smooth transport, don't put anything in the mouth, provide humidified oxygen, and transport. That's the best we can do. Bronchiolitis, RSV. RSV is highly contagious. It's inflammation of the bronchioles. It's spread through droplets. It spreads quickly amongst kids also. Schools, child care centers, this daycare centers, they're church nurseries, can be little breeding grounds for viral illnesses. This is a viral illness, occurs in the first 2 years of life. See it more often in winter and early spring. Bronchioles become inflamed, they swell, they fill with mucus. That causes a lower airway obstruction, and you have a child who is dyspneic, they're febrile, meaning they have a fever, and they can quickly become dehydrated because they don't feel well and they don't want to nurse, they don't want to eat. We need to have a calm, cool, collected demeanor when we approach the child and the parent. We need to allow them to feel that we're in control and we're there to help them. We're going to manage airway and breathing problems. Humidified oxygen, again, is helpful. We don't have it. We need it. We should get it. For adults, long-distance transports or burn patients with inhalation injuries, they need humidified oxygen. Why do we not have humidified oxygen? Because these stinking ambulance services are too cheap to spend $20 on something that they can charge for. Talk about pet peeves. That just ticks me off. Okay. Consider ALS backup. for a patient with that you suspect of having RSV, respiratory syncytial virus, I believe is what that is. Pertussis, whooping cough. It's a bacterial illness spread by droplets. It's becoming more prevalent in the U.S. We once had it on the run. We had it under control, and then we had people who began objecting to immunizing their children for vaccine preventable diseases, and you saw a resurgence in pertussis. There's a very characteristic cough that makes a whoop sound during they cough and they make the whoop sound when they inspire. So they've blown out as they cough, and then they make that whoop sound. These kids can develop secondary pneumonias. They can also they can just get tired from fighting to breathe and fighting to cough and fighting to the point that what happens? They go into respiratory failure because they become bradypneic because they're too tired to fight and breathe anymore. So we're going to manage the airway. We're going to protect ourselves with the appropriate PPE. So we're talking gown, gloves, mask, eye protection, and keep the patient's airway open. So we protected ourselves. Now we need to do something for our patients. Keep their airway open, and then bag assist is necessary, and provide supplemental oxygen even if we aren't bagging them. And that's the best that we can do for them. In the hospital, antibiotics can be used to treat it, but we don't do that pre-hospitally. Okay, airway adjuncts, you know how to use these. You know how to use OPAs. You know how to use NPAs. You know how to use bite blocks, BVMs, all of that stuff. We're going to spend very little time here. You know how to suction. We now know how to use a bulb syringe and suction a pediatric patient. Okay. Blow-by oxygen is used quite a bit with kids since oh man, I'm getting tired. What's the word I'm looking for? Ambient air is 21% oxygen. So if we're providing blow-by oxygen at 6 liters per minute, can either if you have a parent holding the child, you could have them even hold oxygen extension tubing up close to the mouth and nose. That doesn't close in the mouth and nose, and you don't get the child fighting and as upset. So we can push that at 6 liters per minute. If ambient air is 20%, we don't know exactly what we're getting with blow-by oxygen, but we're going to improve that patient's condition. Mild respiratory distress, they can respond really well to blow-by oxygen. And nasal cannula, just like always, from 1 to 6 liters per minute, 24 to 44% FiO2, and they do make nasal cannulae, cannulae, I don't know, whatever's correct. They make those little nasal cannulas. That sounds weird to me, for pediatric patients. They're not tolerated real well sometimes, but they make them. That's why we wind up with blow-by oxygen quite often, because kids just don't tolerate it having their noses and their faces messed with very well sometimes. Non-rebreather mask, we're going to get up to 95% O2 with that. And BVM, I've said all night that we're going to get upwards of 100% FiO2. Blow-by, I have a picture of blow-by here. So this one on the left, see that little cup, and you have that O2 tubing coming in there. That's mom or older sister. I don't know who that is, or maybe that's even an EMS professional holding that cup close to the mouth. But you can do the same thing with holding that end of that oxygen tubing up there. There's that little cannula, nasal cannula there. Things that are different. Two-person BVM technique, you remember that? One person holds and gets a good mask seal, and the other one bags. We have to have a lot of hands. We have to have a lot of team members to do this. But as we taught you in the second and third class periods of your EMT course in CPR, that BVM was meant to be a two-person tool, even though it's not used that way very often. Normally we would just use that EC clamp one-person technique, but we use a double EC clamp if we have a patient large enough. But okay, we know how to do CPR. Shock. Let's talk about shock. Compensated shock, decompensated shock. Pediatric patients compensate extremely well, which means when they cease to compensate, they crash very quickly. So we have to recognize shock. We have to recognize compensated shock. Compensate to the point that their extremities become cold, and pale, if not even cyanotic, and they're mottled. They look like marble, and they don't feel hard like marble, but they look like little veins running through marble. That's modeling of the skin, and that's when everything's shunted to central circulation. And then when they cease to compensate, and they don't have underlying issues with their hearts, so their heart rate responds quickly, and those beta 1 effects, the heart rate goes up, and the contractility of the heart increases really well. Anyway, all right, and then so they compensate really well. Causes of hypovolemic shock in pediatric patients, quite often we see hypovolemic shock from dehydration or secondary to nausea or to vomiting and diarrhea. Have a severe infection. They're febrile. They're losing fluids. They're not nursing. They're not eating. So we don't have to have trauma. It can be a nature of illness caused with diarrhea and vomiting, and then neurologic injury, that severe head injury that could lead to neurogenic shock, anaphylactic shock. Okay. We need to treat shock by assessing the ABCs and intervening as required. With life threats, external hemorrhage, we're in a circulation airway breathing situation, not airway breathing circulation. Signs of shock in kids: tachycardia, poor cap refills. We have cap refill greater than 2 seconds, altered mental status. So if I've said in a child under 3, we're not going to be assessing blood pressure, and if we're looking at a fall in blood pressure as a sign that shock is severe, we're moving to decompensated shock. So what would we see in that 3-year-old and under? If we're not taking a blood pressure, then we're going to start to lose central pulses. So we're going to lose that femoral pulse. And so how do we manage shock in a pediatric patient? Number one, we need to identify it. We're sticking with simple interventions. We're calling ALS. We're controlling bleeding. We're supporting ventilation. If that heart rate falls below 60, we're doing chest compressions in an infant, providing supplemental oxygen. Don't hesitate to go to the BVM, assist ventilations, transport in a position of comfort, keep them warm, turn on the heater in the back of the ambulance with blankets on them. Immediate transport, have ALS meet you on the way, transport to an appropriate facility, which would be a children's hospital if you have it close by. Don't bypass a trauma center where they can possibly stabilize that child and then transfer them out on a helicopter or a ground ambulance, or maybe even a fixed wing to a children's hospital. So anaphylaxis, you see vasodilation, airway swelling, that can be from insect stings, medications, food allergies, have hypoperfusion, stridor, wheezing, inspiratory stridor, expiratory wheezing would be the most common. Increased work of breathing, we know what that looks like now. They're altered appearance. We're looking at that assessment triangle right now, aren't we? Restless, anxious, agitated. If they're old enough, maybe if they're old enough, they might tell you, "I'm going to die. Don't let me die." If they tell you that, get to work. Get ALS on the way. We need to get aggressive in managing this. We see hives, same as we saw when we did when we spent time in the lab with managing anaphylaxis. Just because it's a kid doesn't mean we don't manage it. You need to maintain the airway, administer oxygen, and we need to get that Epi Junior out. That Epi auto injector, that is going to deal with that massive vasodilation, with the alpha effects of that epinephrine. Rapid transport, have ALS meet us. Bleeding disorder, I'm not going to spend time on. AEIOU tips for altered mental status causes. Alcohol. Kids can be given alcohol or can get into alcohol. Epilepsy, endocrine disorders, electrolyte disturbances that could come from vomiting, right? Lose a lot of electrolytes that way, or from being febrile and sweating and losing electrolytes that way. And then insulin, are they hypoglycemic, hyperglycemic? This would be normally seen. Hyperglycemia, that would be seen with an adolescent. That's when quite often you first see a manifestation of type 1 diabetes is in adolescence, and you could see that hyperglycemia, altered mental status, and then kidney failure, far less frequent in occurrence. Trauma, temperature, that's T. Infection, poisoning, and then S. Shock, stroke, seizure, syncope, space occupying lesion, that's a brain tumor, and then subarachnoid hemorrhage. Have that list handy in your little cheat book, and if you're having trouble deciding things that could cause this altered mental status, take a look at it. That's not a bad move. Doctors do it. They don't carry the pocketbooks anymore. They have a computer called a cell phone with them that they can use as a reference material. Not a cheat book, it's reference material. Okay. Seizures can be febrile seizures. They can be seizures can be from epilepsy. After seizures, we're going to wrap this lecture up, and I'm going to record part 3 of Pediatrics tomorrow afternoon. So I'm running out of time tonight, and I've been going since 5:30 this morning, and I'm kind of getting goofy. Not that I'm not always goofy, but seizures same cause of seizures in children as in adults, except for we don't see febrile seizures as often in adults as we do in children. So seizures, a generalized seizure looks different in an infant than it does in an adult. It may just be a dysconjugate gaze. They just look over to the side and they just stare off into space. They can make a smacking, suckling sound and have a dysconjugate gaze. You don't have to have all of these, but that smacking, sucking sound, that alone can be on the same order as a generalized seizure with tonic-clonic activity in adult, because we don't just the neurologic system isn't developed enough to see that tonic-clonic activity in an infant. And then another one that you see that they call it a bicycling motion. The feet move like they're on bicycle pedals, and that's not an infant kicking their feet like they might do. It's more of an alternate, almost a circular motion that may be that accompanied by an abnormal gaze. And I mean, it could be, you could even have all of these. I've never seen all of these together in one kid, but that would be, I think, would be an ominous thing for me to see. I don't ever want to see it. As children get older, they start to have, if they have a generalized seizure, you see more of a tonic-clonic type seizure. And you see absent seizures more in school-age kids. Just stare off, and he just won't pay attention in class. Every now and then he just stares off into space. He sits there for a while, and then he'll finally come back to us. Well, yeah, he may be having an absent seizure, or what we used to call a petit mal seizure. Things that can cause seizures in pediatric patients. Child abuse with head trauma, that can cause seizure activity. Head trauma in general can. Electrolyte imbalances, fever, that's a biggie for us. Hypoglycemia, an infectious process like meningitis, hypoxemia, cerebral hypoxia, and ingestion of medications, poisonings, and then just an underlying seizure disorder, epilepsy. And then as the child gets older, maybe recreational drug use in an adolescent, head trauma, and then an idiopathic seizure. In medicine, if we don't know what the heck caused it, we don't say what the heck caused it. We call it an idiopathic blank. So in this case, it would be an idiopathic seizure. We don't know what the heck caused it. Okay. That might be the worst kind, right? These others, we can put our finger on it. Maybe we can treat that. Idiopathic seizure, what the heck do we do? I don't know. We treat symptoms and we transport. We'll see that in a minute, right? Okay. You can still see a postictal phase. Status epilepticus. Let's hit that very, very quickly here. That is continual seizures every few minutes without regaining consciousness. That should sound familiar back from neurologic emergencies or seizure activity that lasts longer than 30 minutes. Those prolonged seizures can be life-threatening. So what do we do if we have a patient having those things? Well, management. Next slide. You'd think I'd looked at this material before. We're going to manage the airway, and we're going to position the head to open the airway. We're going to suction the mouth, and if they're just, this says that the patient's vomiting, put him in a recovery position. Remember, recovery position from CPR, that's on their side with their leg kind of bent to prop them up so they don't roll over and flop over into a prone position and with one arm extended up above them. I would say that if we can, if they're actively having tonic-clonic seizures, you're not going to get them in recovery position. You're going to have trouble positioning their head to open their airway. You may not be able to get their mouth open to suction them. You may put a non-rebreather mask on them and get some kind of blow-by ventilation type. During the seizure, they hopefully are still breathing some. That is difficult to assess during a seizure. But if we have a non-rebreather on them, or we're using a bag valve mask, then we can ventilate them. Get a nasopharyngeal airway in there so that we have a patent airway, and then we can bag them. It may be more difficult while they're having a seizure. Any rodeo fans out there, see if you can stay on 8 seconds, right? That was a joke. Wasn't a good one. It's best I have. Caregivers may, if seizures happen frequently, they may have a rectal dose of diazepam. Diazepam is Valium. It's called Diastat. They may have given that rectally prior to your arrival. When we're getting a sample history, we need to find out any medications that may have been given. These benzodiazepines like diazepam, their central nervous system depressant, that's how they work to help control the seizure activity. They're also a respiratory suppressant, so we may need to bag assist a child who has been given Diastat prior to our arrival. Preview of coming attractions. Stick around for paramedic school, and I'm going to tell you that in a pinch, if you can't get diazepam into a seizing pediatric patient any other way, you can administer it rectally. You'll need to get an order. You take your normal liquid Valium, and you take the plastic IV catheter that stays in the vein. After you pull the needle out, take a syringe, and you can administer it rectally. Contact medical control for appropriate dose. You may go on to a paramedic program where they don't tell you that. Also, these medications like diazepam and then Versed, you'll learn about in paramedic school. Those can be given with that nasal atomizer that we used to administer Narcan for the route of administration, that as an EMT that you can utilize to administer Narcan. I'm plugging a few of these ALS things just because it doesn't hurt for you to start hearing them now, and hopefully that'll help you learn them better in an advanced program. That's all I'm going to say about that. We'll pick up with meningitis tomorrow afternoon as I continue this lecture. So we'll shut this down now.